Thank you, Dr. Nastakis, Aris, and thank you to the organisers for this meeting, and particularly to Professor Panos Vardas for inviting me to come here once again to Athens. And what I want to do in the next 20 minutes or so is to give you some insight into what is becoming an incredibly active and exciting area of cardiovascular medicine, namely the specific treatment of heart muscle diseases. Indeed, the standard slide that I use at the beginning of my talks wouldn't have been possible 10 years ago. It doesn't mean that I have a Ferrari parked outside the building, but what it does mean is that there is intense interest from the pharma industry about this space, about heart muscle disease. Now, just to anchor the conversation, so this term cardiomyopathy comes from the 1950s. Probably most of you have never heard of this guy. This is Wallace Brigden, who first used the term cardiomyopathy because he was frustrated by the fact that he and others were seeing patients in clinics that clearly had abnormal heart muscles that were not explained by coronary disease or hypertension or valve disease. And even in the 1950s, he was saying, look, we need to move beyond morphological descriptions. We need to be thinking about the cause of disease, because ultimately that will result in better therapy. And it's taken us more than 50 years to listen to what he was saying to us. Since the 1950s, we've organised cardiomyopathies according to what we see when we take pictures of the heart, so according to the morphology and the physiology of the ventricles. And that's defined a number of subtypes: hypertrophic, dilated, restrictive, and so on. And one of the reasons we've maintained this approach to heart muscle disease is because it works. It helps us in planning therapy. So depending on the underlying phenotype, hypertrophic, dilated, restrictive, we have specific interventions, symptomatic and sometimes prognostic. And this has been very successful in many respects. So if we think about dilated cardiomyopathy, which is actually probably the commonest cardiomyopathy, based on trials performed in people with heart failure, whether it be drugs, whether it be devices, whether it be a CRT, these have had impact across the range of people with heart failure with reduced ejection fraction. We see it specifically in dilated cardiomyopathy. So here you see data from northern Italy showing this progressive decline in mortality from the 70s, 80s, 90s to the modern era. So at least in this form of cardiomyopathy, this has been a great success story. And of course, we go beyond that. We have prognostic therapies, but we also have therapies and interventions for managing the complications of dilated cardiomyopathy, whether that be valve disease or arrhythmia, things that you'll all be very familiar with. So you might be forgiven for asking this question: is why do we need a new approach in cardiomyopathies? So one of the reasons is that because we take a somewhat simplistic view of heart muscle disease. We organise it according to a couple of numbers: ejection fraction or cavity size or wall thickness. But hidden within the noise are individual stories. So you can look at this picture and say, this is a patient with heart failure with reduced ejection fraction, evidence-based medication, drugs, devices, etc. End of story. But as an obsessive-compulsive cardiomyopathy doctor, I look at that and say, yes, that's all true, but why does this person have dilated cardiomyopathy? And the reason that's important is because of these individual stories. So if you look here, this is from Denver, but we have multiple series taking consecutive people with dilated cardiomyopathy. About one in four will have a genetic substrate for their disease. If you're genotype positive, you're more likely to experience sudden cardiac death. And that is driven in this particular series by genetic mutations in two genes, lamin and desmoplakin. Illustrating this again, lamin, which is maybe 5% of dilated cardiomyopathy, showing here poor outcomes. Ejection fraction is an important predictor, but it's an important predictor if it's 45%, not if it's less than 35%. If you have a normal ejection fraction but you have non-sustained VT and you're a male and you have a disrupting mutation, you may still be at very high risk of ventricular arrhythmia and sudden cardiac death. Vitamin C, 2%, 3% of dilated cardiomyopathy, same story. As soon as your ejection fraction starts to drop, then you become prone to ventricular arrhythmia. But not every subgroup of dilated cardiomyopathy is about ventricular arrhythmia. PAG3, another few percentage points of dilated cardiomyopathy. Here, the majority of events relate to progressive heart failure in spite of good medical therapy. So these stories are hidden there within the noise of heart failure, but they are real stories. Recently, in the European Society of Cardiology guidelines, we extended this story to include this slightly clunky, non-dilated LV cardiomyopathy phenotype. Why do we do that? Because in everyday practice, and I'm sure it's the same here in any of your hospitals here in Athens, you see this phenotype where it's not a dilated cardiomyopathy. The systolic function may be normal, may be abnormal, but these patients often have these ring-like scars, and some of these substrates are again a high-risk disease with a tendency towards sudden cardiac death. So where this has led us is to say, okay, well, etiology is really important when you're planning therapy. And we've developed, sort of using the same kind of tools that we developed for hypertrophic cardiomyopathy, tools for not DCM, but lamin-related heart muscle disease, for example. So you can estimate the risk of sudden cardiac death. We've done it for desmoplakin, we've done it for filament. Individual tools that you can use to estimate someone's risk of sudden death. And this gene-specific approach to stratification is now included in the guidelines. Yes, look at the ejection fraction, do all the things you would currently do, but if you've got a high-risk gene, then you've got to think beyond the ejection fraction. Okay. Yeah, sudden death, fine. But let me pose another question to you. How good are we at treating symptoms? Well, here's the disease I've spent 30 years of my life with, hypertrophic cardiomyopathy, maybe 1 in 500 of the population, thick heart, myocyte disarray, fibrosis. And patients with hypertrophic cardiomyopathy complain of all the things on the screen here. They get chest pain, they get breathless, they get profound fatigue. And they do that despite the interventions that we have. Sometimes they'll volunteer the fact that they get these symptoms, but other times you have to prompt it, because remember, hypertrophic cardiomyopathy is a lifelong disease often. So people adapt to their disease, and yet they may, since they were 12 or 15 or 20, have had problems getting up the stairs. They can't play with the kids. They can't walk down to the shops. Now, many of those people are limited because of this phenomenon. Systolic anterior motion of the mitral valve, which occurs in about 25% of patients at rest and probably the large majority of symptomatic patients. And how do we treat this? Well, this is what we say in guidelines. We say we use negative inotropes, beta blockers, calcium antagonists. We sometimes exploit the negative inotropic effects of diazepyramide. And if that doesn't work, we then go on to do alcohol ablation or surgery. But we know that the majority of people never get septal reduction therapy, and we also know that the majority of people on so-called good medical therapy are still symptomatic. And so we've seen the emergence of a new story here in hypertrophic cardiomyopathy to meet this unmet need, which you see here in the guideline is the appearance of this new drug, mavacamten. So what is this all about? Well, this mavacamten is a first-in-class, what we call myosin inhibitor. It emerged from an understanding of the genetic architecture of hypertrophic cardiomyopathy. We know that maybe 40% of people will have mutations in the genes that encode the proteins of the cardiac sarcomere. And many years ago now, a guy called Jim Spudich in Stanford had a dream where he was thinking about where the genetic variants in one of these proteins, beta-myosin heavy chain, occur. And they all occurred on what he called the myosin meso, the flat part of the myosin head, shown here in this cartoon, which interacts with the actin filament. By studying this, he and others realized that one of the mechanisms behind hypertrophic cardiomyopathy is, if you like, a tendency towards hypercontractility, because the myosin head hangs on for too long to actin, wasting energy and activating hypertrophic pathways. So it was reasoned that, what if we were to develop a drug which inhibited this interaction? Could we reduce the tendency towards hypertrophy? And in a dish, you could. In an animal model, you could. But what about in humans? So this led to the development of a pivotal trial called the Explorer-HCM trial, which set out to exploit, if you like, the negative inotropic effect of this drug in people with outflow tract obstruction. And here are the headlines from that trial, the Explorer-HCM trial. So taking people who were refractory to conventional medication, placebo-controlled trial, and we demonstrated that there was a reduction in the outflow gradient, there was an improvement in symptoms, there was an improvement in exercise tolerance, improvement in natriuretic peptide, reduction in troponin T. Again, you can see here that 37% compared to 17% had a remarkable increase in a combined endpoint of MYHA class, but also cardiopulmonary exercise testing, peak VO2, which I can tell you is vanishingly rare in a heart failure trial. We don't use it because you can't shift the dial in heart failure trials on peak VO2. It's not the only drug that does that now. We now have a second drug in the same class, aficamten, recently published this year, which shows exactly the same thing. Increase in peak VO2, improvement in MYHA class, improvement in quality of life scores, such as KCCQ. So we now have a new drug option for obstructive hypertrophic cardiomyopathy. But that's not the only story in hypertrophic cardiomyopathy, because HCM is heart failure. We don't tend to put it into the heart failure box because it takes you 20 years to develop your heart failure. But if you wait long enough, the majority of people with hypertrophic cardiomyopathy will end up with left ventricular systolic impairment. And at the moment, we don't have anything that knowingly prevents that from happening. So there's now an increasing focus on non-obstructive disease or performance of the left ventricle. And once again, the myosin inhibitors might have a role here, because I've emphasized the negative inotropic effect, but actually probably the more important effect is that they promote a low-energy, relaxed state within the myocardium. And we now have trials with myosin inhibitors, both mavacamten and aficamten, in non-obstructive disease. Here's the results of a phase 2 study showing average reductions in biomarkers, troponin and BNP. The first of these will report next year. We'll see the Odyssey trial. So suddenly, in a world that I've been working in for 30 years, where we've had no trials at all, now we have loads of trials. And this is just with aficamten, it's the same for mavacamten. Okay. That's great, we can treat symptoms. How about getting really radical and treating the cause of disease? How often do we do that in medicine? How often do we do that in cardiology? We palliate most of the time. Very effectively, but we palliate. So coming from stage left, cardiac amyloidosis. I would argue perhaps one of the first examples in heart failure of an etiology-specific therapy. Cardiac amyloidosis, protein folding disease, occurs in two main forms in the heart, one related to myeloma, plasma dyscrasia, the second related to the deposition of a protein called transthyretin, a transport protein manufactured largely in the liver. And we believe that either as a result of a genetic variant or simply aging, this protein becomes unstable, and then the fragments then redeposit within the myocardium as amyloid fibrils. So we now have a drug which stabilizes this molecule, tafamidis, and oh my God, another randomized clinical control trial with a mortality endpoint. I mean, this is a group of people with a median age of 75, with an average life expectancy of about 3 years untreated. And you see there's 30% reduction in mortality, but more importantly, I would argue, is you slow progression of disease. So here you see the decline in quality of life in placebo versus active arm. Here's 6-minute walk test. Remember, this is a group of people in their 70s and 80s where yes, it'd be nice if they could live for a few more months, but actually to try and maintain independence is even more important. Prevent hospitalization. Just like the myosin inhibitors, it's not the only game in town now. We now have acoramidis, which is another stabilizer, which pretty much the same thing. Reduction in mortality, slowing of decline, 6-minute walk test. So here a paradigm, and I think that the community is still struggling with this. We're not giving this drug to make people feel better, we're giving it to stop them from getting worse. But that is an entirely valid endpoint in this particular demographic. Once again, you discover one drug and then you discover other therapeutic approaches to doing the same thing. So we now have drugs which knock down the production of transthyretin within the cell using silencing RNAs, antisense oligonucleotides. And this, which if this works, is a really radical departure where maybe we could get rid of the amyloid by tagging it with antibody and then using the body's own immune system to remove the amyloid fibrils. New England paper, in principle, this may be possible. And then the final point, I've been talking a lot about diseases which are genetic disorders. And we now have a whole suite of ways of trying to modify genetic variants. Genes that fail to produce a protein, could we actually replace that gene in the cell? Genes that produce a peptide which is toxic to the cell, could we silence it? Could we even edit the genetic code to get rid of the mutation? And all of these things are possible and are being used in other diseases, for example, hematological disorders, muscle disease, etc. Can we do this in the heart? Well, that's a story which is just starting. Here, gene replacement therapy, you've got to get gene into the heart, and that's one of the challenges. So you can use inert viral vectors, adenovirus vectors, to deliver normal gene, wild-type genes to cell. Science fiction, well, it's been done in hypertrophic cardiomyopathy. Next year will be done in ARVC. Will it work? We'll see. Gene editing, actually fixing the underlying genetic abnormality, is that possible? Well, it's possible in amyloidosis. You can take out the mutant variant in amyloidosis using CRISPR-Cas technology. Can you do that in the heart? Do we want to do that in the heart? Is it necessary to do that in the heart? We'll see. But I just use it as an illustration of the fact that we have these different platforms now for genetic therapy which can be applied to cardiovascular disease. And my final point is that I think cardiomyopathy is going to change, I hope it's going to change, the way in which we think about trial design. Our mindset in cardiovascular disease is mortality, mortality, mortality. We want to drive down mortality. And of course that is a completely valid thing to do. But as I hope I've explained to you, is that you have to live with these diseases for 5, 10, 15, 20 years. And so in cardiomyopathies, we have a bit of a problem in that whilst these are diseases that are associated with increased mortality because of heart failure or sudden death, it's over a much longer time scale than is feasible for a hard endpoint-driven trial in the conventional way. So we've made a big move from clinical events to functional measures. And I've shown you some examples of that already. This has been accepted now for approval by the FDA, by EMA, for accelerated approvals based upon functional and symptomatic criteria. We have many ways of measuring function, using quality of life, using VO2, using 6-minute walk tests, etc. We have different strategies for doing that. If you look at quality of life, it allows you to stratify people who are responding and not responding. You can't stratify mortality. You're alive or dead, and you're not sure whether you're alive because of the intervention or because God hasn't called for you yet. Whereas for symptoms, you can say, have you had a small, medium, or large change? Why is that important? Because just about every therapy we use has a range of effects. We don't see it because we average the effect. And if there's a net average benefit, we say that's a success, we will use that drug in everybody with HFrEF. But of course, within that population, you're going to have a heterogeneity in response. And there are going to be people who get better, there may be people in whom it makes no difference, and there may be people, actually, you might be making worse. So I think one of the contributions we have by bringing together the cardiomyopathy way of thinking with the heart failure way of thinking is to start thinking about individualized responses to therapy. So, oops, I'm a year behind. In 2024, the key things are, of course, phenotype, ejection fraction, arrhythmia, but etiology is king. Thank you very much.
Thank you very much, Professor Elliott. It's always a tremendous pleasure to be and have the chance to hear to one of your talks. And if I may, I would like to ask you one question, not on what you already said, but I mean, 25 years ago, we would not have dreamed about everything that you presented today. What is your vision in the next 25 years? Will we be in the chance to get rid of the problem of cardiomyopathy burden?
Yeah. So we've known each other for quite a while. I think you probably know I'm not a natural optimist, but I'm actually really optimistic. And I actually think for the first time we can start thinking about cure. There's a long journey. You know, the things I've been describing, not all of this stuff is going to work. But by targeting the underlying etiology, that gives us the opportunity to potentially think about cure. What we're learning from the myosin inhibitors are that things that we would have said are irreversible may actually be reversible. So we're already starting to see signals with the myosin inhibitors of reductions in left atrial size, reductions in wall thickness, which if you'd asked me 10 years ago, is that possible? No, of course not. Is it possible to reverse fibrosis? Well, if you've got a big area of replacement skull, probably not. But diffuse interstitial fibrosis, maybe that's reversible. So this is going to be a very exciting journey, I think. The other thing which I think is exciting, which again comes with a lot of issues, but issues that are surmountable, is that we have the opportunity for the ultimate in prevention. So if you have a genetic disease and you know what the genetic variant is, wouldn't it be great to prevent the disease from developing in the first place? And we may now have tools for doing that. Of course, you know, there are issues about, because that means treating young people, kids, adolescents. But if we show that these drugs are safe, then maybe actually we can prevent the development of hypertrophic cardiomyopathy or dilated cardiomyopathy, rather than trying to treat it at a more advanced stage. So yeah, I'm optimistic.
I'm glad to hear that.
Professor Elliott, may I ask you something as well? What about the people that they have the indication to take mavacamten, the new treatment of myosin modulators? When we consider someone as an obstructed form of the disease, do we mean as a baseline finding, or we can perform an exercise test and try to see if there is a dynamic obstruction there? I mean, so, because in the Explorer, I think this kind of patient was not included.
So you have maximum provoked gradient as for the selection criteria. To my mind, if you have symptoms and you've got definite evidence for provocable obstruction and you think those two things are related, then that's not a contraindication to use of mavacamten, or in time maybe aficamten.
All right. And what about atrial fibrillation?
Sorry, the only problem with that is that the titration schedule is very complicated, and it depends on both the echo and the gradient. And if the gradient drops below 20 millimeters of mercury, you're supposed to stop up-titration. It was put in as an extra safety measure. And of course, if you only have severe parochial obstruction on an exercise test, it means you've got to do an exercise test every time you up-titrate. Mm-hmm. So I think this is an evolving approach to initiation of these drugs, which is challenging. But it's logistical, it's not theoretical. Those patients should benefit. And atrial fibrillation?
Yes. What about if you have a young patient, all right, and with an obstructive form of the disease, who had a history of atrial fibrillation or a paroxysmal atrial fibrillation once or twice?
With a gradient?
With a gradient, yes,
yeah.
With a gradient.
Yeah.
Are you going to exclude him from mavacamten?
So, this is something we've been debating for years, right? So there's been different practices in different centres around the world for as long as I've been doing this. So 30 years ago in Toronto, that was an indication for surgery. And the rationale, I think, was logical, in that we all follow these patients. We or they think they're asymptomatic, but over time the atrium gets bigger and bigger, they eventually go into atrial fibrillation, and you think, why didn't we do something 5-10 years ago? At the moment, the indication for the myosin inhibitors is based upon symptoms rather than occurrence of atrial fibrillation. I think in my experience, and I'm sure in your experience, I think it's really quite rare to have someone who is genuinely asymptomatic. They may have adapted, and it's why I always ask the question, what things do you avoid? What is it you can't do? Well, I can't go up the stairs and I can't go up hills, but I don't get breathless because I don't go upstairs and I don't go up hills. So I think most people will have symptoms, but if they're really asymptomatic, at the moment, that wouldn't be an indication for a myosin inhibitor.
Thank you. Any questions from the floor?
Yes. Professor Elliott, brilliant talk. Thank you very much. If I may ask, from a surgical, more simplistic point of view, what would you think the role of myosin inhibitors on those patients who have familial or genetic asymptomatic disease as far as progression or evolution of symptoms? What will be the future of that? And also, what is the most objective tool in assessing stabilization, which I think is a very valuable point. Thank you.
So what I thought you was going to ask me was whether we were going to put surgeons out of business with myectomy with these drugs.
I know you won't.
I mean, on that point, it's interesting. If you speak to the teams at Mayo and Cleveland, what they've seen actually is an increase in the number of patients being referred for surgery. Because some patients who you would have sent for surgery clearly respond to these drugs, but as a consequence, more people who were previously stable on medications but actually still limited are being referred for evaluation. And as I showed you, these drugs are effective, but they only are effective in about 30 to 40% of patients. So there's still going to be a lot of people who will have refractory symptoms who may need an intervention. I mean, your first question is very analogous to what Aris was asking. Can we use these to remodel the disease? Are these disease-modifying therapies? And as I said, the early signals are they may be, at least in the context of obstruction. I said, lest atrial size come down, there's this trend, we believe, to reduce LV thickness. We don't know what was going to happen if you stop the drugs. Does all that stuff come back again? It may do. I think only time will tell whether we really modify the disease. The data from the non-obstructive trials is going to be instructive, I think, in that regard. But non-obstructive disease is quite a heterogeneous bag of phenotypes. So non-obstructive disease may be predominantly patients who are sliding into fibrosis, cystotic impairment. They may be pure restrictive. It may be patients who have mid-cavity obstruction are also included in that group. So I think we await the data, but I suspect the disease modification story will start with the next generation of drugs. And there are already new drugs coming through that should be easier to use, that focus predominantly on diastole and get us away from this problem of having to monitor systolic function. And then we'll see if we actually can reverse some of these disease features. You had another question at the end, I think. What was the second question?
The most objective tool?
Yes, sorry, how do you assess? So I don't think there's a single tool. I think these tools are complementary. We recently published a little small data set in a trial of trimetazidine that we did a number of years ago in hypertrophic cardiomyopathy, comparing, for example, 6-minute walk test with peak VO2. And if you look at the correlations, 6-minute walk test correlated better with symptom scores, whereas peak VO2 correlated much better with N-terminal pro-BNP. So they're giving you different facets of the hemodynamic disturbance versus its impact maybe on filling pressures and therefore how breathless you get. So I think it's a composite of things rather than any single measure. But I still think MYHA class is fine. I think quality of life scores, I think we probably should use more in everyday practice. And if you combine that with biomarkers, so surrogates for disease severity such as BNP or troponin in the case of hypertrophic cardiomyopathy in particular, that gives you some idea, I think.
Professor Vardas, sorry, are we going to go on till 4 o'clock or we have to stop?